Hello, I'm Norman Swan. Welcome to this update on HIV/AIDS, Holding the Ramparts. Since the first Australian was diagnosed with AIDS over 25 years ago, more than 26,000 people have contracted HIV, with nearly 7,000 confirmed AIDS-related deaths by the end of 2006. But developments in HIV treatment have people infected with the virus living longer and having a greater quality of life than in the early years of the pandemic. Despite these advances, the challenges continue, with an increase in HIV infection rates since 1999 in some parts of Australia. So tonight we're going to look at the current situation, dispel a few myths and provide some of the latest information on treatment and management of people living with HIV/AIDS. In fact, as we speak, a new medication has just been approved for use in people with HIV/AIDS. As always, there are a number of useful resources available on Rural Health Education Foundation's website, rhef.com.au. Now let me introduce our expert panel to you. Sharon Lewin is Director of the Infectious Diseases Unit at the Alfred Hospital in Melbourne, and she's also immediate past President of the Australasian Society of HIV Medicine, ASHM. Welcome, Sharon.
Thank you.
Miriam Grotowski is a General Practitioner from Tamworth in New South Wales. She's also a member of the New South Wales Health Ministerial Advisory Committee for HIV and the New South Wales Aboriginal Sexual Health Advisory Committee, and is an S100 prescriber, in other words, a GP with a strong interest in people living with HIV and AIDS. Welcome, Miriam.
Thank you.
Russell Levy is a pharmacist at St Vincent's Hospital in Sydney, and he's involved with inpatient and outpatient care of people with HIV and teaches general practitioners through the S100 Prescribers Programme. Welcome, Russell.
Thanks, Laura.
And Rob Lake is a person living with HIV and the CEO of People Living with HIV/AIDS in New South Wales. Welcome, Rob. Thanks. Now, before we go on, this is an important anniversary year, and Australia did, in fact, for many years lead the world in terms of its interventions in HIV and preventing what could have been a terrible pandemic. And one of the people who is credited with that success is the former Federal Minister for Health, Dr. Neil Blewett. Let's hear from him in terms of his historical view of the pandemic.
I believe we should have a national response, because I'd been to the United States over 84, 85, and I was appalled by the fact that there was no national program. I mean, they'd had the disease 3 or 4 years before us, and yet there was no national program in the United States. And so I believe we should have a national program, and that meant getting the cooperation of the states, because the states, under our constitution, are responsible for the management of disease, not really the Commonwealth government. Yet I believe we should get a national response. So there was the question of working with the states to get that, that sort of response. And I suppose another matter of urgency at this time was, once it was identified as a blood-borne disease, we could then begin to develop tests so we could cover our blood banks. And in April 1984, tests from the United States were brought into Australia so that all of our blood banks and our major central city hospitals were provided with a means of checking the blood that was coming in. And we were the first country in the world, in fact, to cover all of our blood banks and major hospitals. I mean, we could do it more quickly than the United States because we're so much smaller country, or smaller in number of centres. What we needed, I believe, was to get the cooperation of the gay community so we'd get them working with us to get the disease identified early. And so basically the program was to fund the gay groups themselves, educational programs, preventive programs, the whole safe sex program. I mean, it's very hard to get people to stop having sexual activity. What we had to ensure that that sexual activity was safe. So there was the whole very controversial safe sex programs, which we left very much to the leadership of the gay communities to educate those people in those communities. 86 sees us beginning to tackle the drug problem, and we looked at various ways we could handle this, but I was again persuaded by the people at the front line handling intravenous drug users that the very best way was to move towards a needle exchange program. First of all, we had cheap needles provided through pharmacists, and the Pharmacy Guild was very good in giving us our support for that rather radical program to provide needles at minimal cost to addicts. But again, pharmacists didn't have the same kind of communication with these people who are in many ways many of them outcasts in the community, that the drug units in the various hospitals had. So we were persuaded that the provision of clean needles and syringes through the services, drug services, was the way to go. It also, of course, helped education, because the provision of clean needles gave the drug authorities and specialists and services a chance to talk to drug addicts about the problems and about the dangers. Unlike many parts of the Western world, we never had a serious outbreak in the intravenous drug using communities. And there's now been a lot of work done which shows that those cities which introduced needle exchange programs had rates of AIDS infection amongst IV drug users at quite minimal levels compared with big Western cities which had no such programs. Indeed, I think I would say that the needle exchange program is one of the most cost-effective programs we've ever had in public health in this country. And then, of course, the next great challenge was the issue of transmission to the heterosexual community. And that led to the program which has been built around the Grim Reaper commercial, which was designed to alert the whole community to the dangers of transmission from the rather narrow communities which were affected to begin with. The danger was that it could be passed more broadly in the community. Now, people said, and rightly so, in view of what's happened, that we rather exaggerated the heterosexual transmission problem. But I would rather be attacked 10 years later by saying, well, you went overboard a bit, Blewett, on that, than not have taken those actions and 10 years later had a serious problem in the heterosexual community. So there are some big challenges now for health authorities in this country to rethink, particularly in relation to the young people coming on, ways of getting over effective anti-AIDS messages.
The former Federal Minister for Health, Neil Blewett. Rob, we've come a long way.
Absolutely, absolutely. That time that he's talking about, and the time particularly before treatments, were sort of dire and not very hopeful. And now we live in a very different time, which is much more hopeful. Complacent? It's a hard word. I think kind of maybe the focus is not on it in the same way that it was.
Tell me about your story.
I've been HIV positive since about 1994.
1994?
Yeah, so nearly 14 years, yeah.
So you've had HIV for 14 years,
yeah,
and you're sitting here in the blossoming health, if I might say so.
Yeah.
How were you diagnosed?
I suppose part of a regular test. In that sort of time, people like me who I suppose were quite engaged with HIV, and I worked in an HIV organisation, we would generally get tested, I think, once or twice a year as a matter of course, and it was picked up at that time. I hadn't been, it was fairly recent. I think they could sort of figure that out. I was on...
Did you get a prodromal illness, or did you have an acute illness?
As I recall, something happened, but it was never something that it was like, oh, this is what that's about. It probably, you know, if I would think about it, it might have been a bit like a light flu or something like that.
So can you remember the day you were told you were HIV positive?
Yeah. So, as I think, I mean, you never forget it, because it's one of the, things become, you know, before and after, and it was very freaky, and I suppose it took a long time for me to come to terms with it, because I think
you were just, that was Russell, that's before HAART, that's before highly active antiretroviral treatment came in, wasn't it?
That's correct. It wasn't until about 1995 when we first started using drugs in combination as part of HAART, highly active antiretroviral therapy. So the treatments that were around prior to that were much inferior to what we have now currently. So
you didn't feel too optimistic, presumably, at that point?
No, because I had friends who were dying and things like that as well, yeah. And sort of was part of a community that was in the middle of all of that, I think, kind of, was, yeah.
And what's been your kind of experience, your treatment experience, you know, the last 14 years?
I started treatments in 2001. beginning of 2001.
So in other words, your CD4 count and everything stayed quite high until then?
Yeah. And I saw a doctor who had a lot of experience in HIV medicine, and I suppose he wanted to leave it as long as possible. You know, he wanted me to go on medications when I had to, rather than use up my options, and I'm very grateful for that. So after I've been on treatments for about 7 or 8 years, and I'm on my second round. So I've been through one lot that stopped working, and now I'm on my second lot.
Is that fairly typical, Sharon?
Yeah, I think what we're hearing is quite a good story, because the treatments work much better when they're started all together at once. So many people that started treatment in the early 90s were perhaps on 1 drug, 2 drugs, and then went on to full heart of 3 drugs. And that sort of approach encourages drug resistance and therefore less effective responses. So I think this is, a good philosophy. Yeah.
So Rob, when you look to the future, is it with optimism?
And for me, and for the people I know who are like what Sharon's talking about, people who have almost got to the end of their options, what we're starting to see is that there's another round of options becoming available. So I think kind of in terms of treatment of HIV, I think I'm really optimistic. I think there are a range of other things happening to particularly older people with HIV that cause concern.
Such as?
The interaction of HIV with other things relating sometimes to ageing, so cardiac...
Heart disease and so on.
Yeah, cancers, those sort of things.
Are you seeing that in general practice, Miriam, with your patients who have got HIV?
Yeah, certainly their problems don't rely just on their HIV diagnosis. They start to have the other health problems that people who age get. So we're starting to look at people living with an illness and getting other illnesses that they're at risk of because of their age and because they're part of the normal population. So,
Sharon, give us a sense of the global and Australian picture here.
Yeah, well, if you look at the current global estimates of the numbers of adults and children living with HIV from 2006 from the UNAIDS, you can see the total comes to around 40 million, and the significant burden of disease is large in sub-Saharan Africa. Although in our own region, in the Asia-Pacific area, we're seeing high rates of HIV up to around 8 million, and particularly increasing rates within countries such as India. Within Australia itself, or within our region, as you already mentioned, we've had a diagnosis of 26,000 cases of HIV. And this slide shows you the change in numbers of diagnoses of HIV, shown in orange, and AIDS, shown in green, over the last 20 years. And if you look at the numbers of cases of AIDS, there was a progressive increase over the mid-90s and then a decline, as Russell mentioned, because of the introduction of antiretroviral therapy. So we're seeing fewer cases of AIDS now than we were 9 years ago. But in contrast to that, if you look at the number of infections, which is the number of HIV diagnoses shown in orange, you can see an early spike in the mid-80s when the test first became available, a decline over the early 90s, but sort of a concerning trend, at least over the last 6 or 7 years, where we're seeing a gradual increase in the number of new HIV diagnoses. You actually look at newly diagnosed HIV infection in Australia. In the last year, we had roughly about 1,000 new cases of HIV diagnoses, and we estimate about 200 of those were secondary to newly acquired HIV infection. These are the data for Australia-wide. The patterns.
Meaning other people are diagnosed a while after they've had it.
Yeah, that's right. So you may have been infected for even 10 years before you're actually diagnosed, and there's certainly a lot of public health rationale to early diagnosis rather than late diagnosis.
Is the virus changing its behaviour, becoming less virulent?
There's no, I wouldn't say that. There's the advantages of early treatment or early diagnosis are multiple. They largely relate to public health and behaviour, as well as access to treatment at the appropriate time, rather than waiting till advanced HIV infection and illness would occur.
And keeping that low down. And it's not uniform across Australia. Victoria is particularly one of the reasons for the increase in rates of infection.
Yeah, so the slide which we looked at previously showed the numbers of new infections across Australia, but in fact the patterns over time have been different in different states. And probably the largest difference sits between New South Wales, where the numbers of new diagnoses of HIV has sort of plateaued over the last 5 years, which is in contrast to what we've seen in Victoria and to some extent in Queensland, where there's been an increase in new infections over the last 6 or 7 years.
Do we know why, Rob?
Honestly, no. I think kind of one of the things that we do know is that we have to keep refining our messages. We have to keep researching to talk to people about what, particularly people who have just been diagnosed, to find out what's been happening for them and what made them make some of those decisions, and use that sort of research to guide the campaigns, because really education.
So maybe it's something as simple as public health education is different between different states.
Yeah, and the focus on it and the intensity of it. Yeah.
So who gets HIV? What are the risk factors?
Well, if we look at the risk factors for people with AIDS in Australia, shown here in this pie chart, the light orange represents people who have acquired it via homosexual contact. So still the dominant risk factor in Australia is in men who have sex with men, and that accounts for roughly about 70% of AIDS diagnoses. And it includes some injecting drug users, but really injecting drug users are only largely at risk if they also are homosexual. If you look at the prevalence in injecting drug users alone, as Neil Blewett spoke about before, we have extremely low rates in Australia of less than 1%. Following that, the next largest risk group, shown here in green, is heterosexual contact, and that accounts for about 20% of AIDS diagnoses. And of those individuals, about 50% of them come from an area of high prevalence, such as Africa or Asia or South America, or have had unprotected sexual contact with someone from a high prevalence country.
But they're very much a minority there.
Yeah.
Do we know the split between metro and non-metro, between rural and city?
Yes, the notifications of HIV usually include the postcode at which the diagnosis was made. It may not be where they live, but we know that if we look at infection rates by location, most infections are in people that live in major cities, accounting for about 80 to 90% of infections, in contrast to non-metropolitan rates of around 10 to 20%.
And what does it look like in the Indigenous community?
Well, Indigenous community also has that same difference between cities and non-metropolitan areas, but if you look at the overall prevalence, and this shows you the age standardised rate per 100,000 people, in green the Indigenous rate and in orange the non-Indigenous rate. And although there's a little bit of bounce on those graphs that we're looking at, in fact the prevalence overall is roughly similar. So although there has been and there still is concern about HIV in the Indigenous community, to date the prevalence is similar to.
And what about the risk factors?
It's interesting, the risk factors are a little different in the Indigenous community. In contrast to what I showed previously, if we look at HIV diagnoses by exposure category in the last 4 years, once again men who have sex with men is a significant risk factor, accounting for about 40% of new infections. But you can see here that the area in green is now much larger, where about 40% of infections are acquired by heterosexual contact.
Rob, do we know the proportion of men who have sex with men who identify themselves as gay versus not identifying themselves as gay but they have sex with men? Because it's a critical issue for general practitioners.
Yeah. No.
I take the answer. No. It took a long time there, but you got there.
I was trying to think if I'd ever seen that figure, and I don't think I have.
Yes.
I mean, the critical difference, particularly in terms of metropolitan, non-metropolitan, is that in larger metropolitan cities, you have really what is an identifiable gay community that people join. That's a bit harder to find in country towns and even cities outside of major metropolitan areas.
But it is an issue, isn't it, Miriam?
Yeah, it's certainly my experience in rural communities is that you have a group of men who identify themselves as heterosexual whilst they might have partners of both sexes, both male and female partners. They don't identify as bisexual and they certainly don't identify as gay, and it means that those public health messages that are aimed at men who have sex with men sort of don't reach that particular part of the community because they don't perceive themselves to be in that group. And
is it a problem eliciting that information that they have sex with men?
It can be. It depends on how you actually approach the questioning, and I guess in my experience one of the ways to do it is to be completely non-judgmental and to ask the question about sexual partners of both males and females.
Have you ever had a cold and you had sex with men?
Yes, that's right. You've seen it, yes.
Who gets tested? I mean, what's your approach to testing in general practice?
So using the information that we've just heard from Sharon, certainly those that are in the high risk groups, so men who have sex with men, people who through your risk-taking history have been identified as IV drug users, or coming from a country of high prevalence, or contact with someone from a country of high prevalence, or if they've been diagnosed with another sexually transmitted infection. Certainly anyone who asks me for a test, even if they have not identified themselves in one of those risk practices, and as is now recommended, a pregnant woman will be offered an HIV test so that we can have the potential of picking up an undiagnosed HIV person and be able to prevent transmission or reduce transmission to the infant.
So what are the obligations on a practitioner, Rob, in terms of this, both legal and if you like, ethical?
I suppose one of the key ones is how well people are prepared for the news that comes from a test. From our perspective as an advocacy organisation.
So this is about pre and post
testing, counselling. It's always really important that because we just never know what the result is going to be, someone has to be given the opportunity to think about what might happen if they have if the test result comes back positive, and they have to. That's what the counselling part of that term is. That exploring that, even to some extent.
How do you do that, Miriam? When you do it, your pre-counselling?
So certainly, particularly around that aspect of support, I actually ask the patients who, if they had a positive result, what would they do? Who would they be able to share that information with, or what contacts perhaps they would like, so that they had some phone number or somewhere where they could actually call should that result be positive. And I think it's really important, particularly in a rural setting, to make sure that that person has actually named or identified someone that they can share that information with, because I think it is particularly, doesn't matter how well prepared someone is and that they think they've got those steps in place, it can be quite a devastating diagnosis.
And what about the legal obligations after the test has been done?
As far as someone being positive, they have a requirement to notify previous contacts, certainly partners that they may have placed at risk.
That's in New South Wales.
That's in New South Wales, sorry. And also future contacts that they are actually HIV positive.
Sharon, what kind of tests are there?
So the standard tests, which when everyone talks about an HIV test, is a blood test looking for antibodies to HIV. That test is an ELISA-based assay, and it's an extremely good test, very high sensitivity, very high specificity, and very well validated and quality controlled across Australia. Usually that's followed up with a confirmatory test, and usually there's a second bleed to make sure there's been no mix-up. And that's the standard way that HIV is diagnosed. There are some other situations where you might use different tests, and one of those might be in primary infection. So if someone's very early, having just acquired HIV,
we do a PCR
within the first few weeks, they may not have made antibodies, but you'll be able to detect the virus. That's sort of a rarer situation. But we use different tests in the early first few weeks of exposure.
So that's more of a direct test for the viral DNA.
You're looking directly for the virus, looking at exactly
RNA,
using PCR for RNA. The newer area that's had some discussion recently is that of rapid testing. They currently haven't been approved yet in Australia, but there are these kits now that you can actually get an answer on HIV, sort of like a pregnancy test within sort of a few minutes. And although there's a lot of interest in those rapid tests, they're probably best still used by laboratories or perhaps practitioners in rural or remote settings rather than patients at home.
What other infections do you look for when you're testing, or if you look for any?
In someone who's presented for an HIV test,
yeah.
Well, it certainly depends on the risks that you've, the risk practices that they've discussed with you, but we would be looking at a variety of tests. If it was a man who had sex with men, you might be looking at a series of swabs, pharyngeal swabs, anal swabs, urine testing, specifically looking for chlamydia and gonorrhea, and blood testing looking for syphilis, the hepatitis A, B and C if their risks are there, as well as the HIV test.
Let's go to our case study tonight. Andrew is a 26-year-old man who was born and still lives in a small country town. He considers himself to be heterosexual. He regularly travels interstate for work and will often go out to clubs, and admits to having the occasional casual unprotected fling with an average of about 4 male partners per year for the last 4 or 5 years. He admits he's often under the influence of alcohol or recreational drugs when having that fling and forgets to use condoms. A recent conversation with an interstate friend about HIV has raised Andrew's concerns, And he's actually come to you, Miriam, who live in a nearby town. You're not his regular GP, to discuss HIV screening. What are you going to do with Andrew?
Well, certainly try and make him feel as comfortable as he can, and reiterate that it's great that he's actually come in for some testing. As I don't know Andrew, I would initially take a more general history from him, so getting some general health information, asking him about medications, vaccinations, and a bit about his past history. And then he's been good enough to provide me with some of his sexual history, but I'd like to take a bit more of a detailed sexual history from him. So he's mentioned that he has some male partners and that some of the sex that he's been having has been unprotected, but I'd like to ask a bit more specifically about the types of intercourse he's been having, whether it's anal, whether it's oral, whether it's receptive or insertive, and what percentage of the time he thought he was using protection. And again, I would ask him whether he was actually having female partners, having sex with female partners as well.
Why is it important to know all that?
It's assessing risks. So it's looking at the risks that he's having, so that when I am then talking to him...
So even if he comes back negative, you know more to counsel him in the future?
Well, yes, I was just about to say, so I could talk to him about his risk practices, perhaps counsel him about some safe sex advice down the track, but also when I'm talking to him about having an HIV test, look at weighing up what the likelihood of a positive is.
And do you warn him about contact tracing?
Certainly as part of his the assessment as I'm going through. So after I've done my sexual history, I would also include the drug and alcohol history and mention recreational drugs. I'm not sure if that's IV use or not. And then I would get into the pre-test counselling that Rob discussed before, and that's looking for supports, talking about what if his result is positive, what he would do, some risk counselling, but also his obligations, which would include the contact tracing and
informing people if you said that. Anything to add to that, Rob?
No, I mean, I think that the support in that early, kind of to prepare is one of the most important things, yeah.
So there are quite a few GPs around who do HIV practice, aren't there?
Yeah, in the major cities there's more GPs than there are in the rural cities, but dotted throughout New South Wales there are some GPs who do practice, yeah. Certainly.
And presumably in Victoria as well, Sharon?
Yeah, there are. There's still, I think, an increasing need for S100 prescribers or GPs with interest in HIV in non-metropolitan areas, but there are a few. So
do you pretty much have access to anything a specialist has in terms of prescribing?
As far as drugs, certainly, and access to a pharmacy, and I also have contacts with a major centre that means that I have support from
So there are outreach services?
Yeah, and infectious diseases physicians.
And what about Victoria, Sharon?
Yeah, Victoria is a slightly different model. We, at the Alfred, have the Victorian HIV Service, which is a central referral service for HIV, and as part of that we have the HIV consultancy, which provides secondary support to non-metropolitan areas. So
would there be many GPs who see a patient, treat them themselves, and they would report them, but they don't get referred to a major centre?
Certainly, I can speak at least for what we call high caseload GPs or S100 prescribers that see a lot of HIV would look after HIV completely independently, unless the individual got sick and needed further specialist care. I think with GPs that have had less experience and have a smaller overall patient load, it's perhaps more of a shared care arrangement.
So, do the enhanced patient care items help you here, or how do you? For billing, because obviously, extended consultations, this is not quick medicine. Certainly,
and one of the comments that you made about access to services in the area that I actually work in the public system to do a lot of my prescribing, and I have access to a clinical nurse consultant who has HIV expertise, and she helps me with those complex patients and the time. But if I was in private practice, the EPC items or the enhanced primary care items and case conferencing and so on would become very useful and very valuable as far as helping me plan my patient's care and get some remuneration for doing that.
We've already got a fax in from Marissa Pilla in North Queensland. I've read conflicting information about garlic and silymarin affecting HIV drug levels. Is this theoretical or is there any clinical evidence? Russell?
Certainly with garlic and some other natural preparations, you have to be concerned. We know St John's wort in particular does interfere with antiretroviral drug levels, and garlic has, although I don't think it's been shown in a head-to-head study, but the way garlic is metabolised via the liver, cytochrome P450, is that there is a potential for interaction with some of your antiretroviral therapies. So garlic, certainly I'd be discouraging patients from taking together with
So is this sort of concentrated garlic, or does Rob not allowed to go to a Mediterranean restaurant?
The end of my Thai food career.
Garlic in therapeutic doses is fine. It's just the high dose you get sometimes from these natural remedies.
And what's this Silimarin?
I'm not familiar with that product at all, actually, so I couldn't comment.
Okay, now let's go back to Andrew, because he's come back to you, Miriam, for his test results, and he in fact is HIV positive. He doesn't have any symptoms. His CD4 count is 325, and his plasma HIV RNA is 100,000. What does all that mean, Sharon?
Well, CD4 count and HIV RNA are the two ways we look at how far the disease has progressed. So the CD4 T cell count tells us whether there's been any immunological damage. And if you look at the chronology of HIV-induced disease over time, HIV is marked by a progressive loss of CD4 T cells, usually over about 10 years. And
this is untreated?
Untreated infection, on an average of about 50 cells per year. And the clinical sort of presentations you might see are really directly related to what that level of CD4 count is. So even at a relatively normal CD4 count of greater than 500, you'll see some immunological disease-related immunological disturbance. Once the CD4 count drops to less than 200, that's really when we start to see AIDS or opportunistic infections or malignancies.
So take us through the natural history then.
Yeah, so the natural history of untreated HIV disease is best described by looking at what happens to your viral load, here shown in orange.
And that's that HIV RNA that we just talked about before. And is 100,000 high?
100,000 is a high viral load, and that's sort of the level that you'll see early in infection. So if you look here at primary infection, or what Rob sort of mentioned was a mild flu-like illness or even glandular fever-like illness, or 50% of people are actually asymptomatic in primary infection. If you have lots and lots of virus around, so you can see here on the orange line, within about 3 to 6 weeks of contacting HIV, very high levels of virus, up around 100,000 or even higher. At the same time, your T cell count can drop early in primary infection, again shown here in the green line where you see a slight dip and then a recovery. And this is often referred to as an acute HIV syndrome. And at that time, you get wide dissemination of the virus throughout all the lymphoid organs. Following that time, the next, as I've shown here, following the wide dissemination, most patients enter what's called a clinically latent phase. And during clinical latency, which is sort of the first 5 to 8 years of HIV, the viral load is still certainly detectable and there's still lots of virus dividing, but it remains at a steady state, and there's a slow and progressive decline in CD4 T cells. And it's really once the T cell count gets below 200 where we might see opportunistic diseases.
So when you say T cells, you mean CD4?
Yeah, I mean CD4 count, where you might see opportunistic infections, malignancies, and AIDS.
And you start to qualify for an AIDS diagnosis.
That's right.
Do you know what, with highly active antiretroviral treatment, what the conversion rate is to AIDS in current treatment?
Well, it's dramatically slowed down. So if you look at the number of individuals that die from HIV or AIDS-related deaths, on next slide, you can see there's been a major reduction in death after the introduction of highly active antiretroviral therapy. This is an old slide from a paper back in 1998, but it shows you that around 95, 96, as Russell mentioned before, once highly active antiretroviral therapy became available, we saw a dramatic decline in deaths in countries that introduced HAART. And this decline in deaths has actually continued in what's called the sort of late HAART era. So early HAART, where the drugs actually weren't as good as we've got now, a significant decline in AIDS-related, HIV-related and all deaths, and that's continued to decrease right until now.
So when somebody comes in to see you and they say you've given them the diagnosis, and they say, well, how many years of life am I going to lose here? I mean, how short is my life going to become because of this diagnosis, even with the best treatment? Do we know the answer to that? We
don't really know the answer because the drugs haven't been around long enough, you know, just on 20 years really, just on 10 years really, so we don't know that they've been around long enough to say, but we know from measuring people's viral loads and their T cell count that life really could be next to normal. And so what I tell patients is that they have a chronic illness and that's something they're going to have to live with forever, but if they take their medications, their life expectancy may well be within normal range.
Miriam, let's go back to Andrew. Because Andrew rather sheepishly tells you something that he didn't tell you last time, which is actually that he married Melissa recently, and they've had a long-term relationship, in fact, for the last 6 years.
Okay, so I guess that raises a whole lot of other issues. I would ask specifically whether he's sexually active with Melissa, and if so, whether he's...
They want to have babies.
Okay, well, I presume he's sexually active then. Is he using protection at the moment? And if he is using protection, then I guess I need to discuss, am I aware of his CD4 count and
Yep.
viral load at this stage? And they are...
That's 325 and
Oh, okay, the ones that he's currently come with. So I guess I would be talking to him about, is it him that wants to father the child? Are they looking at alternative donors for the sperm? Has Melissa been checked from an HIV point of view? Is she aware of his status? And so I guess just checking how much information he's given to Melissa.
So if you could drive his viral load down really low, as you do with heart, do the sperm ever become safe?
I wouldn't like to make that call. I would certainly, this is quite a specialised area because there are discordant couples looking at trying to have children, and I know that there is a centre in Melbourne that sort of specialises specifically in this area, and this is when I'd be seeking some expert advice and giving hopefully the correct information.
So you're the
to
expert,
Andrew.
Sharon.
Well, the Alpha played a critical role in setting up the discordant couple program. It's been very successful, actually. And our advice is no, there is always a risk of transmission, even with a viral load. You might measure in your blood is less than 50, but if we actually looked in the seminal fluid, we might detect virus. So it's not a safe approach to just assume that you're not going to transmit HIV.
And I think, is that why they use the wording, I've always said this to patients, about undetectable rather than zero? So it means we can't detect it, but it's assumed that possibly there's some virus
It's
somewhere.
probably good psychologically, but it's also because of the assay, because the assay only detects to 50 copies. If you have better assays, which there are around, it will detect down to 1 to 2 copies per mil. So people have still got virus there.
Yes.
And if you actually measure seminal fluid, you'd also... you may find more virus than in blood. So what's done in the discordant couple program is that we do make sure that the patient's on maximal therapy, has the lowest viral load possible, and then in fact there's an approach to wash the semen and to actually wash off the seminal fluid, so there's just the actual spermatozoa and it's a form of artificial
And is there still a risk in that? Or is...
The risk is really, really low. We have experience in Australia is much less than internationally. The biggest centres are in Europe and in places, particularly in Italy, they've done thousands of these sort of procedures. The risk of transmission is virtually zero. It's very low.
So send them off to Melbourne.
Absolutely.
So Russell, what we're going to do for treatment, actually we've got a question here from a general practitioner in northern New South Wales, who read the paper today, because at the time of broadcast, we were doing a live broadcast tonight, but people will be watching this recorded. I think the Therapeutic Goods Administration announced the approval of, is it raltegravir?
That's correct, yes.
A new medication, and the GP wants to know what that is.
Okay, well, raltegravir is one of the newer agents that have just been released, and it's probably not the sort of thing you'd be going for first line anyway, so
right.
you probably delay it to later on in
so
treatment.
It makes good newspaper coffee, but
it does.
It's not coming to a clinic near you just yet.
It's really good news though, because we have a lot of patients who will benefit from that, certainly patients who have, for whatever reason, not succeeded with therapies that are a bit more conventional. So it's great news that the Pharmaceutical Benefit Scheme will be subsidising that. Well, actually, that's not the case at this stage. It's been approved by the TGA, sorry.
And this is what Rob was talking about earlier, and Sharon, is that luckily so far, as elements of heart, which we were just going to go on and talk about in a minute, fail because of resistance, there are at least some new medications in the pipeline to refresh it.
That's right, and the last year's been particularly good in that respect. So we're in a fortunate place right now.
So take us through the rationale, the life cycle of HIV and where these new medications hit.
Okay, well, remember the goals of our therapy with antiretroviral therapy is to completely suppress the virus. We want to stop it from growing entirely by using the drugs. And by doing so, we're able to prevent the reinfection of new CD4 cells and that ultimate decline. So we want to keep our CD4 cell counts high, and we want to suppress our viral loads with the drugs. So to figure out how the drugs fit in together, if we look at the life cycle of HIV, Just very briefly, remember it's a retrovirus, so that means there's RNA inside the viral capsule. There's also some very important viral enzymes, namely reverse transcriptase and viral proteases, and also viral integrases, which come into play during the life cycle. So once your retrovirus, your HIV, combines with the CD4 marker protein on the outside of the cell, the RNA is released into the cell, and it then migrates, it then undergoes reverse transcriptase to become DNA, migrates into the cell cytoplasm, and then takes over control of the cell pretty much, and directs it to produce a whole lot more new virus particles. So if we look more closely at where our drugs are actually working, what we have available, the first stage of the virus life cycle is the binding and fusion, and we do have one drug that's currently available for use at this stage. It tends to be reserved for later in treatments for patients, but there's also a developing area of new drugs to do with binding and preventing HIV from actually entering the CD4 cell in the first place. But moving on to our reverse transcription, that phase of the virus life cycle, we actually have two different classes of drugs which work at inhibiting the viral reverse transcriptase: the nucleoside reverse transcriptase inhibitors and the non-nucleoside reverse transcriptase inhibitors. So they prevent the virus from turning itself into DNA. Next up, we have viral integration, which I said as before occurs inside the cell nucleus, and by this process, the new viral DNA becomes incorporated with the host genetic material. And we have one drug here now, the one you just mentioned, raltegravir, which inhibits this process. And towards the end of the life cycle of the virus, we have the protease inhibitors, which work at preventing the production of mature virus particles for release into the circulation by inhibiting viral protease enzymes. So we have about 5 classes altogether which we can use. How do we actually go about using those together is another question. I have listed for your interest the different types of drugs that we have available based on those classes. So if we look at the nucleoside reverse transcriptase inhibitors, these are the ones that are stopping viral reverse transcriptase. And these are some of the older drugs that are here. We still use them quite frequently though. I've just listed their names and also some of the abbreviations which you may sometimes see. We do tend to discourage use of abbreviations wherever possible though. So there's the nucleoside reverse transcriptase inhibitors. Next up we have the non-nucleoside reverse transcriptase inhibitors, not quite so many of them, but importantly etravirine down the bottom. It's also a newer one that's been released in the last year, not yet through the TGA, but available to some patients in particular populations. And thirdly we have the protease inhibitors. There's quite a few of these ones. And on the last slide for the drugs, I've just listed the integrase inhibitors, raltegravir, and also that fusion inhibitor I mentioned first up, which we tend to save for patients who have failed on other therapies. So we have around about 20 drugs or so altogether to use, quite a lot. You might think in our armamentarium, but how do we actually go about using those for antiretroviral therapy? Well,
so just a matter of interest, if you're on, a heart is 3 drugs, isn't it?
That's right, yes.
So let's say the protease inhibitor, you're picking up resistance and you're testing to the protease inhibitor you're on. Can you switch protease inhibitor, or that whole class of drugs is gone for you?
With the protease inhibitors you can switch drugs. It depends what kind of resistance you detected. However, with drugs like the non-nucleoside reverse transcriptase inhibitors, if you become resistant to one of those drugs, then you tend to be across the board for the class. The whole class can be eliminated.
And some of them help each other out, don't they?
Yeah, so you can actually often you can combine 2 protease inhibitors, and because of their pharmacokinetic interactions, they tend to protease inhibitors are potent inhibitors of the cytochrome P450 system or liver metabolism. You can use a very small dose of one protease inhibitor like ritonavir with a normal dose of the other protease inhibitor, and it boosts the level. So they help each other out in a pharmacokinetic interaction.
Rob, how much trouble have you had with side effects?
I've been really lucky with side effects. I think partly because I kind of didn't have too many goes earlier on. So pretty basic. I mean, my a good friend of mine who's been HIV positive a lot longer than me, struggles daily and particularly with gastro sort of side effects. So it's the managing the side effects that we're also getting a lot better at, and we're getting a lot better information of what's the impact of diet and things like that as well. but also, as Russell was saying, I think kind of generally the side effect profiles are getting better and better for experience.
And how hard is it to remember to take them, you were hearing? Because if you forget to take them, your viral load can start slipping up again.
Absolutely, and it is adherences, which is what we call it, is difficult. Again, what makes it easier is the less number of pills. I mean, I've recently gone from I don't know, about 10 down. I'm on about 5 now a day, and things like that.
I remember
really,
in the early days it could have been 25.
Yeah,
you know.
And that was just your HIV. You know, that wasn't your statins or your other sorts of pills as well. That was just your HIV, or your vitamins, and just that thing about remembering them. So there's a lot of strategies. Often, if people have difficulties, it's good to talk to their GP or talk to a pharmacist, and you get those little dosette boxes, and you put your reminders and stuff like that.
So the range of side effects is quite big. I mean, the protease inhibitors cause that lipodystrophy and cardiac effects and so on.
Well, as time goes by, we learn more and more about what the etiology is of the fat redistributions, and it tends to be the protease inhibitors as well as the nucleosides, both involved in there. Exactly how that works, we're still not exactly sure. But certainly there's that as a side effect which worries a lot of patients because it's a visible thing that can be seen and detected. There's a lot of cardiovascular complications which are occurring as further down the track to do with the use of medication, and also disease.
Well, premature coronary heart disease.
Well, it's elevations in lipids and predisposing factors to developing heart disease. Yeah.
Can I just say, I think the lipodystrophy is one of the things that's a real issue in terms of the fear of people starting treatments, the fear that might happen, and the more. The better we get at figuring out what combinations avoid that, the easier it is, because that, in terms of a facial, a visible stigma,
For GPs and pharmacists watching who might never have seen this is where you really get a sucked-in appearance to the face because the fat goes in the cheeks.
Sort of atrophies off your face, and it's very marked and evident, and people feel really. That it's really obvious.
It's off the limbs as well, and sort of goes to around the central distribution, and so it can be very...
And you're at increased risk of type 2 diabetes.
And but it's also very distinctive in its look, or can be.
So some of the, it's taken a while to tease out what the etiology is with fat loss and fat deposition. They're probably quite separate processes, and some of the earlier nucleoside reverse transcriptase inhibitors like AZT, which most people would have heard of, or DDI or D4T, tend to have a much more significant effect on inducing this lipodystrophy, which is largely due to poisoning mitochondria, or something called mitochondrial toxicity. And the newer antivirals like tenofovir or abacavir, which many people with HIV are now on, the association with mitochondrial toxicity is far reduced. So
if you're not an S100 prescriber, we could go on forever about the fine details, and one often hears HIV physicians doing this, and is really the important thing for the GP who might not be seeing a lot of people with HIV is to really encourage adherence and just try and dissect what the side effect profile is, and if necessary consult.
Absolutely, yeah.
And support the patient,
adherence is the most important thing. Absolutely. What about, Sharon, treatment holidays? There was a trend a few years ago that, if I've got my CD4 count high and my viral load is really low, why can't I have a break?
Yeah, that became quite popular in a number of settings. People thinking it might reduce my side effects, or it might reduce the total time that I can be on treatment. But I think what's sort of been the nail in structured treatment interruptions grave has been the SMART study, which was a very large study with over 5,000 people, where people looked at continuous treatment versus interrupted treatment. And to the investigators and everyone's surprise, people that had interrupted treatment had an increased mortality and morbidity, and largely from non-HIV related illnesses.
Really?
Yeah, so increased morbidity secondary to cardiovascular and neurological events, or hepatic, rather than AIDS related events.
What was the reason?
Well, there's a lot of work now going on to try and understand that, but it may be related to overall immune activation, so that high levels of constantly tickling up the immune system, gives you greater, perhaps increased risk for atherosclerosis and other sort of vascular events.
So a general practitioner in country Victoria asks, what role does diet play in the management of slowing the progression of disease? Miriam?
I think diet's really, really important, not just for HIV patients, but for all patients, and particularly patients with chronic illnesses. I think specifically with HIV, it's useful to have some dietary advice from people who have experience with HIV patients, and particularly with some of the drugs that they're on, ways of for a lot of my patients' experience with protease inhibitors is that they get diarrhoea, and so diet that can assist with that, which will be high in roughage, and also some other, like Metamucil and other agents that can reduce diarrhoea. But I think diet is really important, and it's something that a patient can do
in a sense, it'll
themselves.
slow the progression of the disease indirectly by allowing you to stay on the medication.
Yep, longer certainly, and also help them generally with their health. If you're eating well and you're feeling well, then you're more likely to feel like adhering and doing things, participating
Rob?
in life generally.
Yeah, and I mean, particularly the thing with diarrhea and things like that is the absorption, the fact you're not getting the energy and sort of like keeping well. So while it's as much about there's really good dietary advice around about managing side effects. Generally, for people with HIV, diet is critical in terms of a whole range of other things as well.
A general practitioner in South Australia asks, how do you monitor for resistance?
In our area, we can actually order resistance testing via, it has to go from our lab down to one of the larger labs, and we actually get a profile report to come back which tells us about resistance in the
So
drugs.
is this the same as bacterial resistance? You just culture the virus against the various antibiotics, antiviral, retrovirals? What do you do?
Resistance testing is a genetic type test. So you get the genetic sequence of the bit of the virus where the drugs work, and then we know what the genetic sequence.
So you're looking at the mutations of the virus.
Looking at the mutations of the virus. There actually are tests exactly like bacterial resistance testing, which we call phenotypic testing. They're not available in Australia. We use genotypic testing.
But how then do you make a clinical decision? If it's coming back the virus is resistant, do you then start doing PCRs to see what the viral load is, or what, to see if it's actually having a clinical effect?
It's actually the other way around. Once you will get alerted to look for resistance if there is an increase in the amount of virus present. So if someone's had an undetectable viral load for a few years and then suddenly it's detectable on 2 occasions, it has to be above 2,000 copies to do the resistance testing, then you'll be thinking, well, why has this suddenly come back? Is it because the patient's not taking the tablets? So is it adherence? Is it because there's some problem with absorption of the tablets? Or is there resistance? And that's when you would look for whether there's specific mutations there or not.
A GP in Tasmania, Russell, asks about long-term toxicity.
Yes, as I mentioned before, there's increasing evidence coming about what sort of toxicities we're seeing, and we're also refining the treatments now, as Sharon was saying before, by not using so much the older drugs that were perhaps used 5-10 years ago. Some of your nucleoside reverse transcriptase inhibitors like AZT and DDI and stavudine. These are the ones that tend to be associated with the long-term toxicities. We talked about mitochondrial toxicity and how that can be associated with some fat redistributions and also some lipid abnormalities or sugar abnormalities as well. So the long-term toxicity is there. I guess it's more a matter of us refining how we use the drugs to prevent them from happening and developing new drugs along the way that aren't so toxic.
A pharmacist from central Queensland asks this, they've heard, they keep on hearing the term post-exposure prophylaxis, needle sticks and things like that. What's the status of that now?
That's a very effective intervention where you can give anti-HIV drugs within 72 hours of exposure, whether it's occupational from the needle stick or non-occupational for sexual exposure. And you can give drugs to minimise the risk of transmission. And on average, it's estimated that it will reduce your risk of acquisition by about 80%. Sometimes we use 2 drugs, sometimes we use 3 drugs in that setting. It depends on the nature of the exposure and whether we know the source is HIV positive. The availability across Australia, I believe it's available in all states. The administration of it's a little bit different. It's available in all states except Tasmania, actually, but all other states have programs where there's availability of post-exposure prophylaxis.
So almost the morning after pills?
Almost the morning after pills. We discourage from regular use, but in fact, we've been running a large program from the Alfred across Victoria for non-occupational post-exposure prophylaxis over the last few years, and about 20 to 30% of our patients are repeat presenters, so people do come back. So that's an issue for education intervention and risk reducing behaviour.
A general practitioner in the Northern Territory asks Rob, given the information she's heard about circumcision and the protection of circumcision, would you recommend men who have sex with men to be circumcised?
No. I mean, I think there's some there's some interesting evidence and research around the role of circumcision in developing countries, and I think the research was done in Africa. It doesn't translate to a Western, it doesn't translate to an Australian context at least, and I think the message that we always give is, condoms are safe sex protection. I mean, the idea of stepping away from any of those sort of things, even to because it just starts to muddy the water. I think we need to actually kind of keep some consistent messages, and we've done so well out of condoms and clean needles so far. I think we need to stick with messages like that.
But the implication behind this general practitioner's question is, should, for example, you be encouraging circumcision in Aboriginal communities? I probably would defer to Sharon or...
well, the evidence in an African setting where it's high prevalence and predominantly heterosexual is that circumcision will reduce your chance of getting HIV or acquiring HIV by about 70%. It looks really very convincing in that setting. We don't yet know whether it works in the setting of men who have sex with men or with anal intercourse, or whether it's an effective intervention when there's a low prevalence like we have currently in the Indigenous community and even in the gay community. So in
many Indigenous communities there's traditional circumcision anyway, so it's an almost not a necessary question. Yeah. Thank you. Fascinating programme. What messages do you have for people to take away from it? Rob?
I think a message to this audience is that it's great that people are watching a program about HIV. It's great that people are taking the opportunity to understand what's different about HIV in Australia and what their role in ongoing prevention and care might be. And I think the other thing that we've alluded to a bit through this is that one of the key factors in whether someone comes forward for testing, whether someone kind of comes back for results and care, is the treatment they get. And stigmatisation and negative attitudes, we all have to work to try and change those so that people are able to come forward and get the treatment and the care that they need wherever they live.
Russell?
I'd like to stress the importance of adherence to medication for the success of therapy. We need to be aiming for something like 95% adherence rates to antiretroviral therapy to get the best effect, to maintain that viral suppression and increase the length of time we can keep on using antiretrovirals. And it's a very hard figure to obtain, so we need to think about strategies to try and help patients maintain that high level of adherence that's required.
Miriam?
Look, I think general practitioners are really well placed to be part of patients with HIV's care. I think they can take whatever role they wish. If they wish to be involved as a support person and in monitoring therapy, they can do that. If they're interested in being more involved, they could certainly contact their local state or Australian Society of HIV Medicine, or ASHM, to find out more information, whether it's to attend courses or in fact become an S100 prescriber. But I think GPs are well placed to be part of that supportive network. Yeah, and
very impressive network of GPs in this area. Sharon?
I think we've been extraordinarily lucky in Australia by having such effective public health campaigns like needle exchange programs and openness about condoms, and we live in an environment of very low prevalence, but I think people should be reminded that new infections still occur 1,000 a year and it's increasing, so we can't get complacent about those public health messages. And it's really important to diagnose HIV early, because it then gives the patient the best opportunity to perhaps modify behaviour, treat co-infections, and then access anti-HIV treatment at the right time.
Thank you very much to you all. I hope you've got a lot out of this programme. If you're interested in obtaining more information about the issues raised, there are a number of resources available on the Rural Health Education Foundation's website, rhef.com.au. Now, don't forget to complete and send in your evaluation forms and register for CPD points by completing the attendance sheet. Our thanks to the Department of Health and Ageing for supporting this programme, and to the Australasian Society for HIV Medicine for their assistance in developing it. But thanks also to you for taking the time to attend and contribute. I'm Norman Swan. From all of us, bye for now.